So today we'll do stomach cancers. So in stomach cancer, we'll go through these points. There are different types of cancers that can happen in the stomach, and but you should remember certain most prominent ones. But the first one that should come in mind is supposed to be surface epithelial cancers or adenocarcinoma. Adenocarcinoma. Because the surface epithelium of the stomach has a lot of gastric glands, like you can see here. They have gastric glands, so it's adenocarcinoma. Now, most of these tumors are induced because of H. Helicobacter pylori. Helicobacter pylori or H. pylori. H. pylori induced chronic gastritis. H. pylori induced chronic gastritis. And other types are gastric neuroendocrine tumor, sorry. Then you have GISTs, MALT, and DLBCL. Just remember them for now, we'll do it later, but also remember that in these two, you never do resection. Resection is never done as treatment, okay? Now we do epidemiology of adenocarcinoma. Well, what is the epidemiology of adenocarcinoma? Gastric adenocarcinoma. Gastric adenocarcinoma epidemiology. Whatever, you get what I mean. Number one, that it's the third most common cause of cancer death. So, this is gastric, which basically means the stomach, adenocarcinoma, and it is the third most common cause of cancer related death. Then, it is most common in men around the age of the 50s, in their 50s, yeah? And it can also be present in younger people, but make sure if it is in younger people, then it is hereditary. Okay? And remember that gastric adenocarcinoma is very aggressive. Very, very, very aggressive. Okay. Now we did epidemiology. Now we do risk factors. What are the risk factors of gastric adenocarcinoma? Number one risk factor is H. pylori infection. Let me write these things in blue, I guess. H. pylori infection is the number one cause of gastric adenocarcinoma. And other risk factors can be eating smoked food. Basically, the Japanese people, they eat a lot of smoked food. Pickled food and smoking. So, H. pylori infection, smoked food, pickled food, and smoking. H. pylori infection, smoked food, pickled food, and smoking. Okay? Then, genetically, what are the risk factors? Approximately 10% of those cancers are genetically linked. They have familial genetic burden to either familial genetic burden or hereditary cancer syndromes. And it is number one is hereditary DARY diffuse gastric cancer. Okay, hereditary diffuse gastric cancer. Okay, now remember, just remember diffuse gastric cancer for now. Later on, I'll tell you that it is a type of stomach cancer. Macroscopically, it looks a bit different. Then Lynch syndrome or Lynch syndrome. I don't know how to pronounce it. Syndrome. And number three, familial adenomatous, adenomatous polyposis. You can add coli or I don't know, maybe just familial adenomatous polyposis. Okay. If you want, you can also add what mutation is causing it. For hereditary diffuse gastric cancer, it is CDH1 mutation. For Lynch syndrome, it's microsatellite instability. Yeah. For familial adenomatous polyposis, it is the APC mutation. Okay. SCAD CDH1 mutation for hereditary diffuse gastric cancer, microsatellite instability for Lynch syndrome, familial adenomatous polyposis for APC mutation. Okay, great. Now what? We did genetics. Good job. We said Helicobacter pylori is a risk factor, right? Helicobacter pylori is a risk factor. But what does it do? It causes chronic gastritis. Causes chronic gastritis. How does it cause chronic gastritis? This bacteria colonizes the mucosa and lives in the mucin of foveolar epithelium. Now, what is foveolar epithelium? What is foveolar epithelium? Where is foveolar epithelium? I think they're trying to say foveolar is epithelium is the foveolar cells wherever they are. Okay, and then during chronic inflammation, these foveolar cell epithelium they undergo intestinal metaplasia. They undergo intestinal metaplasia. So basically, what happened? The bacteria caused a stressor kind of in the foveolar epithelium, inducing intestinal metaplasia. Okay, then this also leads to the first thing that it was doing was it was causing intestinal metaplasia. The other thing that helicobacter can do is cause malt lymphoma and DLBCL. We'll go to it later, but not now. Highlighted in the histology with if you have a stomach biopsy kind of, how will you check if it has Helicobacter pylori? How will you check it? You will add these two stains. First stain is Wharton Starry. Second is Gimsa. Gimsa. Giemsa. Okay? Now, this was all we need to know for Helicobacter pylori. Later on, we go to now precursor lesions where we will do more of it. Now, we learned that Helicobacter pylori was causing intestinal metaplasia of the foveolar epithelium, right? Yes. Now, this intestinal metaplasia is the main cause of cancer. It can become cancerous. And this dysplasia is either can be either low grade or can be high grade. Okay? The same thing. First thing we did was because of Helicobacter pylori. The other reason why this can happen, intestinal metaplasia का दूसरा reason क्या हो सकता है? Atrophic autoimmune gastritis. Atrophic autoimmune gastritis. Great. Which happens when? In pernicious anemia. Pernicious anemia. ठीक है. और भी precursor lesions होते हैं इसके, but these are a little bit linked to genetics. So the first one, the after intestinal metaplasia, let's say this is the second one, you have intestinal type adenoma. Intestinal type adenoma. It can be either tubular or villus. Okay, this is because of APC gene. Which APC gene was causing which genetical disorder? I think it was causing hereditary adenomatous polyposis, familial adenomatous polyposis, or hereditary same thing. Familial adenomatous polyposis. Okay. Yeah. Then intestinal type adenoma is tubulus or villus. Then you have foveolar type adenoma, which is linked to familial adenomatous polyposis. Okay, now keep this in mind. Not all APC mutations will cause familial adenomatous polyposis. Okay, some of them do, some of them don't. But over here, the foveolar type adenoma will cause is linked to FAP. Yeah, it's linked to FAP, but it's a type of precursor lesion. Remember we had pyloric glands in the stomach? Yes. Pyloric gland adenoma is also linked to FAP. And remember oxyntic glands in the stomach? Oxyntic glands, they are also linked to, actually no, they're just there. It's also adenoma is also a precursor lesion. So we need to tell 5 precursor lesions for, while recapping, just make sure that there are 5 precursor lesions that you're supposed to say. Okay, now we look at macroscopically. Most common cases of stomach cancer, where do you find them? The most common cases are here in the antrum and in the pylorus. Okay, because these are also the most common cases where you get what? Chronic gastritis. What is the main cause of chronic gastritis? Helicobacter pylori. What is the other way of getting a cancer? I'm just recapping whatever we learned. Pernicious anemia causes what? Pernicious anemia causes atrophic autoimmune gastritis. Atrophic autoimmune gastritis. AUG. Atrophic autoimmune gastritis. Very well. This is fine, I guess, till now. Advanced lesions have 4 types. Early lesions are flat. You see? Now, macroscopic classification of advanced gastric cancer. Type 1, this is elevated. Type 2, little bit ulcerated. But over here you see type 3. It is ulcerated and it is also diffusing. And this is flat, but it is diffusing. Then you have protruding type, and then you have a little bit elevated type, and this is flat, this is ulcerating, this is complete ulceration, which is the worst type. Yeah, now microscopically microscopically, I don't know, we should go to microscopically yet. Yes, let's just go microscopically. Microscopically, adenocarcinoma has multiple histological types, yeah? And remember, you have tubular growth pattern, poorly cohesive signet ring, or mucinous. Tubular growth pattern, signet ring, or mucinous histological types, and they all have different types of prognosis. These are histologically, yeah. You have tubular, poorly cohesive signet ring, and mucinous type of stomach cancer. Types of stomach cancer. We did microscopic. Now we do types of stomach cancer. Always remember there are two types. Intestinal type, which is more common, and you have diffuse type, which is less common. And it is also called poorly cohesive. Yeah. Intestinal type can be divided into four types: tubular, papillary, solid, and mucinous. Tubular, papillary, solid, and mucinous. Tubular, papillary, solid, and mucinous. Okay. Over here you can see intestinal type. Macroscopically, they are bulky tumors frequently grow along the cohesive fronts. Okay. An ulcerative and infiltrative kind of tumor. So you see, they are just going deep and affecting this area mainly. So they are large irregular ulcers with heaped up margins in the lesser curvature of the antrum. Where was the antrum, guys? It was here. Antrum is here of the stomach. Yes. So you see, it's here. Then you have, what was the different types? You have tubular, papillary, mucinous, and solid. Tubular, papillary, solid, mucinous. Tubular, papillary, solid, mucinous. And if this is intestinal. Over here you will see like a one big one. Over here maybe we can't see it properly, I guess. Now we are doing diffuse. Diffuse is very interesting. It's characterized by signet ring. Signet ring. And they diffusely infiltrate the gastric mucosa. Yeah, they are in the gastric mucosa. Desmoplasia results in the thickening of the stomach wall. You see, the stomach wall is diffusely thickened. That's why it was called diffused. Now it's called poorly cohesive. And it looks like lentis plastica, in which people used to carry water before. Most important thing that you need to know, that it is not related to HPV, Helicobacter pylori. It is not related. Wait, not, don't say Helicobacter pylori. It's Helicobacter pylori or H. pylori. Let's just call it H. pylori. It's not linked to H. pylori. Yes. We did types of stomach cancers. Now we do clinical presentation. What's the clinical presentation of stomach cancer? We have images to help us. We see lesser threlate sign. Okay. Anthracosis nigricans. This is Krukenberg tumor. Krukenberg tumor of the ovaries. This is SMJ nodule, which is Sister Mary Josephine nodule or something. I'm not sure. Joseph nodule, yes. And it's all, remember, Krukenberg tumor is always bilateral. It happens because of diffuse gastric adenocarcinoma. And so it will have what cells? Signet ring cells. Yes. Very nice. And I think that is, wait, yes, now spread, metastasizes to the lungs. Lungs is not, oh my god, they just call this lungs, it's liver. Sorry, I think I'm hallucinating. So it goes to the liver. Metastasis is to the liver. Kuchenberg tumor is bilateral. Ovaries, metastasis, diffuse gastric. Yes. Virchow's node. This will be positive in case of what? Gastric adenocarcinoma, which is the left supraclavicular node. Is Virchow's node. Left supraclavicular node. Okay. Good job, good job, good job. Now we do TNM classification. If the primary tumor cannot be assessed, then it is TX. If there's TO, there is no evidence of primary tumor. T is that it's carcinoma in situ. Basically, it's like a precursor lesion. T1, the tumor invades the lamina propria. Oh my god, what is lamina propria? This is lamina propria. It's mucosa, and some mucosa makes lamina propria. This part. So if it crosses that, then it is stage 1 tumor. Then tumor invades the lamina propria or the muscularis mucosa. A little bit here will also be stage 1, okay? But T1A, and then T1B is invades the submucosa. Oh no. Yeah, invades the submucosa. T2 is invades the muscularis propria layer. T2 invades, you see it's in the muscle now. T3 invades the subserosa layer without invasion of the serosa and adjacent surfaces. This is the serosa. T3, it's in the serosa. T4, tumor penetrates the serosa. Tumor invades adjacent structures. Now it's crossing. So basically there are T4, four stages of the tumor. NX is regional lymph nodes cannot be assessed. There is no lymph node metastasis. No regional node metastasis is NO. And 1 is metastasis to 1 or 2 regional lymph nodes, and 2 is metastasis to 3 to 6 regional lymph nodes, and 3 is more than 7 regional lymph nodes. So you have N3. And M0 is there is no distance metastasis. M1 means there is a distance metastasis. Okay, great. We did staging. Staging is done. We did clinical presentation. We did tumor growth and spread. We did TNM staging. Now we just need to do treatment and prognosis. Very well done. Now for treatment and prognosis. Let's come here. Treatment. For treatment, what was the cause first of all? H. pylori? Yeah, you can remove it with antibiotics because it's a bacteria. Yeah. Then surgery of peptic ulcers is performed if there is a lot of bleeding. Bleeding is high. Then you do surgery. Yes. If you do surgery, then it's good. What kind of surgery will you do though? Either partial or complete. Partial or complete gastrectomy. Yeah. And in earlier lesions, you can either do mucosectomy. Tumors can be tested for what expression? HER2 overexpression. And if there is a HER2 overexpression, you can give them trastuzumab. Okay. Prognosis. We talk about prognosis is very poor in advanced cases. 5-year survival rate is around 10%. Early cancer can be cured by early cancer can be cured by total resection. Yay. Now let's try to do this without looking at it as active recall, shall we? Okay, now let's go down and paste it here. And when I'm back to Chicago, I feel it. Another river. Yes, done. I want to remove this. Delete, delete, not paste. Delete. Fuck! Sorry, I swear. Fuck. Sorry. Delete, delete. And when I'm back to Chicago, I feel it. Delete. 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 Why am I recording all this? Oh my god. Anyway, go here, go here. And now we talk about it. Yeah? What are the tumors of the stomach? What are the tumors of the stomach? We can say the first one was adenocarcinoma, gastric adenocarcinoma. Then we have GIST, we have MALT, we have DLBCL. We remembered no resection here. Yes, adenocarcinoma, GIST, DLBCL. Am I forgetting something? NET. I'm forgetting NET. Yes. Now, epidemiology, I think it was the third most common cause of cancer related death. It was most common in men in their 50s. And it can happen to young people too, but then it is genetical. Risk factors is eating smoked food, smoking, genetical, and pickled food. Yes, smoked food, smoking, genetical, and pickled food. Genetics, we did 3 genetical disorders in this one. We had hereditary, uh, diffuse gastric, hereditary diffuse gastric carcinoma. No, hereditary what? Hereditary diffuse gastric cancer. Yeah, okay. Gastric cancer, which was because of CDH1 gene mutation. Then we had Lynch syndrome, which was due to microsatellite instability. And then we had familial adenomatous polyposis. Yeah, which was because of APC mutation. Okay. Great. Now we had precursor lesions. We had 5 precursor lesions. 3, 4, 5. One was intestinal metaplasia, which was happening because of 2 things: chronic gastritis, H. pylori related. Then we had pernicious anemia causing autoimmune atrophic gastritis causing intestinal metaplasia. Then we had foveolar epithelial adenoma. We had oxyntic gland adenoma. We had pyloric gland adenoma. And what else did we have? Intestinal type adenoma, which was most common. Intestinal type adenoma. Great, we did precursor lesions. Macroscopically, It was happening mainly in the pylorus and the antrum of the stomach due to gastric chronic gastritis. Early lesions were flat, later lesions were barely visible. Poorly cohesive ones are thickened and stiff in the gastric wall. Okay, now types of stomach cancer. We remember we did, there are two types of stomach cancer. One is intestinal type, and one was diffuse type or poorly cohesive type. Yeah, intestinal type was tubular, papillary, solid, mucinous. Diffuse type is only one, which was signet ring. And yeah, tubular, papillary, solid, mucinous, signet ring. Very nice. What was it? It was never not related to Helicobacter pylori. Okay. We did that, and now we did types of stomach cancer. Clinical presentation. Clinical presentation. What was the first thing we saw? We have Krukenberg tumor, which is bilateral, and it is because of diffuse gastric carcinoma. We have SMJ nodule, and the third thing is metastasis to the liver, and also Virchow's nodule, which is the left supraclavicular nodule. Yes, those four things. Then what did we have? Think, Ayushi, think. Yes, how did we forget? Laser Thrillat sign. Lat sign. Okay. And then what did we have? Laser Thrillat sign ho gaya. Fir Anthracosis nigricans. You get an idea, whatever. Yep. Done. Very, very good so far. TNM staging is usko utna bhav nahi dena hai, it's fine. TNM staging mein you can just say that you have 4T and I think 3N and 2M. Okay. What was the layer of the stomach? Mucosa, submucosa, muscularis propria. Mucosa, submucosa, muscularis propria, and outer layer. So serosa. So this is T1, T2, T3, T4. Okay, done. Then we do the treatment. Treatment. Yeah. Treatment. First thing was antibiotics. Then you check for HER2 production, overexpression, and if it is there, you give trastuzumab. Then, if it is early stage, the best thing is to do partial or complete gastrectomy. Yeah. Prognosis, only 10% survive 5 years. So it is really poor. And I think we are done. Right? Yes. So, oh yeah, one thing we can add to that is mucosectomy is also possible as one of the treatments. And now we are done.